Hey everyone, welcome to Exploring Health Macro to Micro. I'm your host, Parker Condit. In the show, I interview experts from all areas of health, and this can be in areas you might expect, like exercise, nutrition, and mental health, while other topics may be in areas that you're less familiar with, like understanding how exactly our healthcare system works and the toll it takes on our doctors. And that's something we go over in today's conversation. My guest is Dr. Scott Ellner, who's a general surgeon and healthcare executive. Dr. Ellner is a doctor of osteopathic medicine and holds a master's degree in healthcare management from Harvard University, among a long list of credentials which can be found in full in the description. And I think this will be an interesting perspective for a lot of people to hear, because it's easy to rail against the healthcare system here in the US, and a lot of times doctors sort of get lumped into that negative light, probably unfairly. And I'd say more often than not, they're just as unhappy as their patients being stuck in a system that is less than optimal, to put it lightly. So today you're going to get an insider's perspective and hear what it's like from the doctor side. And we start off with a very under-discussed topic, which is physician impairment. And that's understanding what happens when senior and well-respected doctors start declining mentally and it starts putting patient care in risk. We later go into reimbursement models, which is how money moves in the system. And if you want to understand how decisions are made in the healthcare system, understanding how the money works is a crucial first step. And then finally, we get into some current events in healthcare and we talk about where we see things going in the future. So by the end of today's episode, I think you'll walk away with a better understanding of how money flows through the healthcare system, and you'll also be able to bring more empathy to the doctor-patient relationship, now having a deeper understanding of the physician side of that interaction. So without further ado, I hope you enjoy my conversation with Dr. Scott Ellner. Dr. Scott Ellner, thanks so much for being here.
Great to be here.
Yeah, so today's conversation, as kind of consistent listeners are probably going to understand or are going to have an understanding of, most of these are around the patient side or the consumer side, understanding the healthcare system. And, I think rightfully so, I bring about a fair amount of criticism to the healthcare system, and there are certain things that, require to be called out. One of the things I don't think gets enough attention is understanding the medical side from the medical doctors, the understanding the empathy and the compassion that's required on that side, because they're also operating in a healthcare system that is obviously not ideal. You have a handful of stories and anecdotes that we're going to go through to get a better understanding of that side. And that's where I think you're going to offer a really unique perspective. So I'd love to start just getting an idea of how you describe physician impairment, because I think that story is going to encompass a lot of the relationships that are involved with the education within healthcare, and then also understanding just kind of the frame of the rest of the conversation. So I think starting with understanding physician impairment will be a great place for us to start.
Sure, and I appreciate you bringing up this topic. It's an important one. We've seen the issue of physician impairment become ever more so present, actually because of the pandemic. And I want to just remind the listeners that physician impairment doesn't mean you can't perform your duties well if you have a chronic disease like diabetes, or you have some sort of physical type of disability. Impairment occurs when you cannot perform your duties in accordance with the ethical obligations of the Hippocratic Oath, do no harm. And the challenges that we're seeing with healthcare, not just with physicians, but also with other healthcare professionals, is that the stress, the administrative burden, the challenges with something such as workplace violence are actually creating an environment where healthcare professionals are feeling more stressed out than ever. They're suffering from mental health issues, behavioral health issues. Sometimes they resort to illicit drug use, or such as opioids, and becoming addicted to painkillers and alcohol abuse. And then there's this loss of the idealism of why many of us went into healthcare, and that was to really serve people, to serve vulnerable populations, care for others, to improve their health. And when the stress gets so intense, and by the way, on average, uh, most people do experience some form of stress 10 times a day. Whether it's traffic, whether it's finding a parking place, whether it's having an argument. In healthcare, particularly working in a hospital, it's 10 times an hour. So the level, the intensity of that stress, caring for people, and then forgetting to care for yourself leads to impairment. And we've seen this unfortunately, with physicians and a high rate of death by suicide. And so I think it's an important topic that we really need to address to help patients and consumers of healthcare understand that, physicians went into their professions to serve a calling. But with all the challenges that we're facing today, and we'll go into more detail about those challenges, there are sometimes issues that arise which, we need to help. We need to care for our healthcare workforce, essentially. Show compassion.
Yeah, exactly. I think it's a great point. And it's just so often, I've talked to so many doctors, and it is exactly that. They're just as frustrated that they can't practice medicine in the way that they want to, that best serves patients. But again, it's just we're operating in this system that doesn't necessarily facilitate that as well as they'd like or at all. Can you give an example of physician impairment just to kind of bring this concept down to earth for a lot of people?
Yeah, this is, and again, I want to stress, physicians can perform with having disabilities or other chronic diseases. Impairment is when your emotional balance, your well-being gets to a point where actually there's a risk of creating harm toward the patient, harm toward the healthcare professional themselves, or to the people around them. And so let's talk about anxiety and depression. We saw mental health became an important issue and continues to be a very important topic to discuss in relation to supporting our healthcare workforce because of all the demands put on them. When depression starts to set in, and I'll be honest, as a physician myself, I've experienced episodes of depression. You start to lose that drive. You start to lose that ability to stay focused on doing what's right for the patient. You're just trying to survive and get through the day. And it may be because you're overwhelmed. It may be because you're having stress at home. It may be because you're not feeling fulfilled in the work that you're doing. And you're actually at risk of people suffering harm. And what we talked about a lot, particularly with situations that occurred during the pandemic, was moral injury. Feeling like we just could not perform to our absolute best level or potential to serve our patients. And it creates this perpetual cycle of not feeling good about yourself, not feeling good about what you're accomplishing, and then losing your desire to actually do what's best for the patient. Mental health is one issue. When you resort to substance abuse, we saw in my experience, there was a colleague who was addicted to opioids. He was having a nurse practitioner in his office actually write prescriptions for him because he had low back pain, which he developed from a weekend outing playing softball. Over time, his demeanor changed. He became incredibly short with his staff, demeaning, belittling in some instances, and then actually started having relationships that were inappropriate with patients. Of course, when it gets to that point, people need to call that out and people need to address it because it will not only perpetuate, but it will hurt other people. It will create collateral damage. So, those are instances. Certainly, there are other instances I've seen in the operating room where someone who is overtired or overworked loses their composure and starts throwing things or acting belligerent towards staff or other people. And it's unacceptable, but you have to realize there are factors that lead to this happening.
So generally speaking, I mean, I'm sure this can happen at any point in your career. But do you find it happening later in your career with like cognitive decline and just sort of a compounding effect of this high stress situation constantly being kind of imparted on the physician?
So that's a good question. So as we talk about the more senior physician as they get toward the twilight of their career, so I wanna separate that out a little bit because I think that's important. We in residency, as a surgical resident, I was the chief resident in a very difficult esophageal case on a 21-year-old young lady who unfortunately had problems with swallowing. And my attending surgeon at the time was 84 years old, well regarded, globally known for his work. And I could see he was struggling. He was struggling. It was a difficult case. And it was hard for me to watch. And I also knew we had a young lady on the table here. And every stitch that you place, every suture to repair that esophagus. And this was a redo case. So it wasn't like it was, new tissue. This was a difficult case because he was renowned for his work in this area. You had to be precise. And I knew he was struggling. And it wasn't because, of anything more than just at that point, your ability, your dexterity, even your judgment isn't what it was, in your 30s, 40s. So I made a very, very tough decision to ask the nurse quietly to call one of my other attending surgeons to come in to help. That's difficult to do. That's difficult when you know somebody who is incredibly well respected within their field and has done great things, has published hundreds of articles. And then you have to surreptitiously go around and ask someone to step in for them. It's like an athlete, it happens in pro sports. Same thing. They're just not on their game. They're not in the flow state like they used to be.
Yeah, but it's hard to, as a rookie, tell the superstar athlete on the team that, they're not the one carrying the team anymore or anything like that. Even a coach can be in a tough position there, to bring it to the sports analogy. So that's a case what you described where action was taken, and to be a resident and to be able to do that, I'm sure it takes a lot of courage. Can you describe the relationship between residents and attendings? Because that dynamic can lead to what I want to get into next, which is going to be a situation where nobody says anything, which probably happens quite often. But I think if you can start with describing sort of the power dynamic within the medical education system, I think that'd help frame the rest of the conversation.
Yeah, at least when I went through medical school and residency, which was the late '90s, 2000s. It was before there were work hour restrictions, fully work hour restrictions, which I think now looking back is a pretty good thing in some ways, and maybe not so great in other ways. But the most important aspect of training in different medical specialties is this authority gradient. As a medical student, you are essentially on the low end of the totem pole. And you're there to learn, you're there to listen, and the ability to speak up, it can be scary because you don't want to look bad. You're also being graded or on your performance, and sometimes you're being asked a lot of questions. The term we use is pimping, which is you get pimped on questions. And yeah, not and it's weird, but yeah, that's what they use as a term. As a resident, now as an intern is a first year resident. Again, you go right back to the bot. You're at the bottom, and then as you ascend throughout your residency and eventually become a chief resident, you still have to defer to your attending. Now, the attendings also have their hierarchy, where you have junior attendings, and you have more senior, and then you have the luminaries, who are well regarded in different societies and who have published. And there's a term I want to use that I think is really important, that needs to be emphasized, and it's called psychological safety. I want to make sure I'm correct here. I believe it may have come from Amy Edmondson out of Harvard, who really studied behavior around how people interact in group settings when there is a need to speak up. And many times there are situations where somebody is about to maybe operate on the wrong body part, and nobody speaks up because there's a fear of actually speaking up. Can you imagine? Can you imagine that happening on an airplane? Can you imagine that happening in any other industry?
Are you familiar with the Checklist Manifesto by Atul Gawande? If I'm saying his name
I
right?
very much am. Yes.
Okay. Yeah. So
Yes.
I think it's examples in that book that they ended up taking in the medical field a lot of the protocols from the aviation field for that exact reason. Like I think now it's like you mark appendages with a Sharpie
Mhm.
prior to surgery to avoid things like this.
Well, and actually, Atul Gawande was somebody that I highly respect, and did a lot of my research after using the surgical safety checklist in the operating room, because I think that checklist saves lives. And the whole approach of going through a pre-briefing and talking about the case beforehand, and then doing what's called a timeout before you do anything on a patient to ensure that you're doing something in the right location is incredibly important. And then afterward, you talk about it. What went right? What could we have done better? But that it's important to have the comfort where anyone in that room, regardless of their status on that authority gradient, can speak up, particularly if they see something that's not right.
So it's a tough dynamic, right? Because obviously the medical field has evolved so well because knowledge has been passed down in a very deliberate way. And one of those ways is through this sort of gradient of, the more senior leaders within an organization passing that information down in this particular way. But at the same time, how do you maintain that authority and that structure for the education and sort of the order of the operation, but still have people feeling safe enough to speak up in these situations when it's very easy to be in that room, especially with a very esteemed senior leader, and you see them doing something wrong, but you're like, everything else in your mind is like, it's like the halo effect, right? Where you're like, "Oh, they can't possibly be doing something wrong, right? They know so much, they know so well. I must be mistaken on which leg we're supposed to be operating on. So it's a very tricky problem. Have you seen progress in, I guess, since then, because you've worked as a healthcare executive, so you've kind of seen different sides of this and how administering policy can help improve. Have you seen improvements in this case since you were a resident?
Yeah, it's a great question. Absolutely. And I think so. Just to let the listeners know, it's much safer today to go into the hospital and have your interaction with your physician, whatever it is, because of people like Atul Gawande and others who have promoted what's called high reliability principles or high reliability organizing principles. And these were tools that were adapted from the aviation industry, the nuclear power industry, in order to ensure that in high risk environments like healthcare, we implement programs where if you see something, the approach we teach people. And in my last few health systems that I ran, we taught people, how do you speak up? And the best way to do that is to ask a question or say, I have a concern. And it's a way that doesn't escalate to the point of creating tension. It's a way of escalating to the point of creating inquiry and allowing people to have a conversation. So looking back today, with the older surgeon that I was in, that case around the esophagus, I probably would have said, instead of, behind the scenes asking the nurse to call my attending, I probably would have said to the senior surgeon, Dr. So-and-so, I have a question. Is there something that I can do to help you? Is there something we can do to address this situation? I'm seeing a lot of blood. And do it in a non-threatening way uh, that maintains dignity, respect, and the authority.
Mm-hmm. It's almost like searching for clarity versus conflict.
Absolutely. And I think that's where we get into trouble many times is instead of approaching that in an effort to define clarity, we create conflict, and then that creates tension, and that leads to sometimes bad behavior.
So going again, I want to go back to the situation where something doesn't get said and there does end up being like a very adverse event. For anyone who's in medical school or residency, is there adequate training? Maybe you can speak to when you went through it and maybe where we are now, for dealing with like the emotional toll of possibly losing a patient in a situation where it was just a tough case. It was more of a case of, I didn't say something when I could have. Because yeah, having all the tools and the skills required for whatever specialty you're going into as a medical doctor, obviously required. But this seems like one of those things that happens and probably, I mean, I've just seen like the lack of nutrition training, going through medical school. So is there adequate skill training around emotional resiliency and emotional tools to deal with loss as a medical doctor?
Parker, that's such a great question. How do we teach the younger generation of healthcare professionals, physicians, nurses, those who are going into the allied health professions to deal with loss and to develop resilience or hardiness? I would say there's so much information that we're trying to learn today. And then on top of that, add how to document appropriately in the electronic health record, which has only added more of an administrative burden. I think the skills to teach people how to be resilient during tough times is sort of overlooked. There are some organizations and training programs and schools who are now thinking about emphasizing. I don't want to call them soft skills because they're not. These are important skills that are.
That's fine. That's a term that people can latch on to.
Right, but the reality is, the first time you see someone die and they're under your care, it's heartbreaking. And I vividly remember a patient, a 47-year-old man who I was caring for. He was actually seeing me because he was interested in weight loss surgery, but he was having pain in his right side. And we did a CT scan after a few weeks, and it turns out he had a metastatic colon cancer. So colon cancer had spread to his liver. And he died not even 6 months later. And I remember talking to his wife and his 12-year-old daughter just before he was passing, explaining to them that there was really nothing more we could do. It takes a toll on the clinician. And, it's okay to cry. It's okay to show emotion. It's okay to be sensitive in those instances because you care. And we don't have to always be desensitized, because I think what that does is it hardens us to the point where we become cynical. We lose our purpose or sense of purpose at times.
Have you found that there's ever environments that don't necessarily facilitate the compassion and the ability to feel your emotions, and then people do end up getting desensitized and cynical, and then you end up seeing people exit the industry? I'm thinking more examples in nursing than physicians, more so around like the pandemic, and also issues around like safe staffing ratios. The example that kind of comes to mind is not in directly where there's somebody under your care, but a nurse couldn't do everything that he or she would have wanted to because the staffing ratio wasn't adequate in a particular facility. So are there issues like that as well?
Yeah, I think that's an epidemic of the epidemic, is the ability to create the appropriate levels of staffing so people aren't so overwhelmed that they feel like they're not doing their best. And even before the pandemic, I think that was starting to happen. And what the health systems are facing today is workforce dislocation. We're losing really strong nurses who love what they do, but the financial dynamics don't make it easy to continue to support the labor force, because it is the number one cost for health systems is labor. And to strike that balance and have the right ratio so that people don't feel overwhelmed and are working to their highest potential, it's difficult to navigate that fine line. And I think that we saw the requirement of bringing in a lot of outside contracted labor into the workforce because a lot of people left. So some of them are coming back, but still it's incredibly difficult to recruit people into the healthcare profession because they know how difficult it is.
So we're now parlaying into the financial side of things, which I think is required for people to understand the dynamics of the healthcare system. So physician burnout or healthcare professional burnout, physician impairment, do you think any of that's related to, I mean, it has to be related to the financial model that we're operating in. I think it'd just be easiest if you first describe the predominant payment model of fee for service within the healthcare system. And then we can kind of talk about how that influences decisions kind of up and down the board.
Yeah. So to make this, just try to simplify it as much as I can for a very complicated payment methodology in the healthcare industry. Historically, what you did, the more you did, if you provided a service, whether it was a primary care visit, whether it was performing an operation, you got paid. You got paid a certain amount. That's called fee for service. So you provided a service and then you were reimbursed. Reimbursed is not the correct term either, because reimbursed means that if you take everybody out to lunch and it's on the company will reimburse you for the full amount. That doesn't happen. Instead, you get a payment, which could be maybe 60% of what you charged. So again, there's some nuances there. So fee for service is you charge a fee and you get paid a certain amount from a third party, typically. It doesn't come directly from the patient. Now, the patients do have to now pay co-pays. They have a deductible, which is incredibly expensive now. But the reason why fee for service and the mechanism of how healthcare has evolved into this payment structure really stems from the early part of the 20th century, back in the early 1900s, with the development of insurance, employer-sponsored insurance programs. So essentially, the medical care that people were receiving over time was other people's money. And so today, we're trying to combat healthcare expenditures and the costs. By 2030, the healthcare expenditures will be over $7 trillion, 20% of the US GDP. And despite, challenges in those rising costs and trying to provide value in healthcare, we continue to outspend other countries. So the fee for service model, while I think it can work, what it does lead to also is sometimes something called unnecessary medical services. So doing things that quite aren't really necessary.
I think there's nuance there as well, because a lot of it can be done defensively, because we also live in a very litigious country where there can be procedures done because there's a potential risk a few years down the line that you as a physician is going to be on the hook for missing something on a CT scan, right? When somebody comes in with what you think is dehydration and you miss an aneurysm or something like that. So there is also, on the financial side, there is a responsibility on the population of loving to take people to court and taking doctors to court. So there's that side of it as well. So that's fee for service. There's a shift towards something called value-based care, or value. Can you describe that? And maybe I'd love to actually just hear your thoughts on value and what do you think that's a viable solution kind of moving forward?
Right. So value-based care really came out of work that was done through the Affordable Care Act. And by the way, the Affordable Care Act wasn't really about affordability. It was about improving access.
Right.
So value-based care is now you get paid for the value you provide to the patient. And the value equation is the outcome divided by the cost. So if you have high quality, a great outcome, and low cost, that increases value. And so the payment models now today, and we'll talk a little bit about Medicare because I think that's important to discuss. Medicare is moving from a traditional approach where it's fee for service to now Medicare Advantage, which is a value-based product that is run by commercial health plans that incentivizes physicians to provide value. So the physicians are paid based on their performance on managing chronic diseases or keeping people healthy, keeping people actually out of the hospital and potentially performing less and thus by lowering costs. So Medicare fee-for-service, or the traditional Medicare, which was passed in 1965 in the Social Security Act, was you do something, you get paid for it. Medicare Advantage or value-based care is today we do things that will bring value, hopefully will bring value at a lower cost and will provide high quality.
So it sounds like on the surface, when I first started learning about this, value-based care seemed like a great proposition. I also really enjoyed the idea of Medicare Advantage. It also seemed like a great proposition. I have concerns about Medicare being shifted towards private companies or in the form of Medicare Advantage, and the control kind of going away from the government to these private entities for our aging population. I also have concerns about the financial incentives in that model as well. I guess at a very surface level, fee for service encourages more procedures, more things to be done because that's where the revenue's tied. On the other side, value-based care, it sort of incentivizes less things to be done. And, you can kind of keep more money as long as they don't end up having a really adverse event, like ending up in the hospital. So maybe if you can just speak to a little bit more depth about the good and the bad of value-based care.
Well, I think you described it pretty well. So as we transition or try to transition into value-based care delivery, the idea is to minimize the amount of care services, medical care services, expensive care services, in order to keep populations of people healthy. The challenge is that when you're dealing with populations, there are always going to be a few outliers. Mm-hmm. And so, for example, let's say you have a managed care plan that is responsible for Medicare Advantage. And they have an algorithm that says if a woman under the age of 65 has an abnormal pap smear, instead of referring them to an OBGYN for a potential workup and a biopsy, they have to have 4 abnormal pap smears, which is a lot cheaper than a biopsy, before they can get a referral to a specialist. The problem is you're going to miss some aggressive cancers.
Sure.
Now, it's a numbers game, if you think about it, right? So one person may not benefit from being part of this value-based delivery system, but as a whole, it does, in an effort, decrease costs and keep people relatively healthy. So the downside is that some people are going to miss being diagnosed or have a delay in diagnosis, misdiagnosis or delay in diagnosis. And then that gets into the legal ramifications that you talked about and the duty of care and breaching that duty.
What about I'm not sure how to phrase this. The Medicare population, 65 and older, obviously it's a big population right now, and the shift has been drastic from Medicare to Medicare Advantage over the past decade, and it's continuing to ramp up. Like it's 50% of Medicare patients or Medicare beneficiaries are on Medicare Advantage now. Is there a danger of the continued shift towards Medicare Advantage? I don't necessarily know that there is, because I don't understand macroeconomics that well. I do have concerns about maybe in some of the big players, right? Because it's not evenly distributed, this Medicare Advantage population either. It's like United has a huge stranglehold on that industry, and they're already a monster of a company. I just don't know if it's great for one company to have so much control over what is our biggest industry in this country, as you described, going to be $7 trillion, trillion with a T, by 2030. And for reference, like when a lot of people are saying, "Oh, I wish we had more money for insert your favorite thing," in this country, they usually say, "Oh, if we spent less money on defense, we could do this other thing." But we spend way more on healthcare than we do on defense. So just I want to call that out for people who maybe don't appreciate how much money we spend on healthcare here.
Well, the insurance companies are doing well. I will say, however, the Department of Justice is scrutinizing the big insurers, commercial insurers like United Healthcare. Yeah, and United Healthcare or United Health Group is having a bit of a Boeing moment, right? So Boeing, as you know, is having its struggles. We talked about the airline industry. Well, a door flying off mid-flight from your airplane is not a good thing. United Healthcare has been in the news recently because of a cybersecurity attack on their Change Healthcare division, which they purchased for a couple billion, I think, and are using it for adjudicating claims, which means paying out claims through to their providers who are under United Healthcare contracts. It's not a good look because United Healthcare is really struggling for getting those claims out because of this breakdown. Department of Justice is also looking at United Healthcare division of Optum Care for antitrust, because I believe it's now roughly 1 in 10 physicians is now an employee of Optum Care. So you're creating what's allegedly an anti-competitive environment, where it could be said there might be alleged attempted monopolization of the industry. And then one other case that United Healthcare is facing goes back to what we were just discussing with Medicare Advantage. So the idea with Medicare Advantage is the sicker the patients are based on a risk severity coding system, the more the plans will get reimbursed by the government. So if somebody has diabetes with chronic renal failure, or so their kidneys are failing from their diabetes, and you document that into your electronic health record, you will get paid more the following year, including United Healthcare. What United Healthcare did is they scrutinized millions of claims using an artificial intelligence model, machine learning, looking at if they were coded appropriately. And then those that were undercoded, they upcoded them. What they didn't do is look at the codes that were overcoded or upcoded and bring them down to what they should have been. So the Department of Justice is now looking at that case for an alleged False Claims Act violation. So again, the insurers are really positioning themselves to, I would say, the insurers are positioning themselves to really have a stranglehold over the healthcare industry.
I think that's a great example of. I think there is absolutely nefarious activity sometimes when there's this much money involved. It's a great industry to make money, but like what you described makes sense. If a patient is sicker based on more conditions, severity of conditions through what's known as a RAF score, it's going to take a little bit more resources to keep them healthy in a given year. So the plan should be compensated higher for taking on the risk of that particular patient. If you take on a whole bunch of those riskier patients, you should get paid more. The problem is it's like first order thinking, right? It's kind of like chess moves back and forth. Like, so the compensation is available for in an appropriate way, and then the other side goes, well, how can we take advantage of this maybe just a little bit more? So I think things are never really done in a really nefarious manner. It's just there's an incentive, and then you get a bunch of really smart people because there's trillions of dollars at stake to go, how can we get more of that? And then there needs to be more regulation to close up some of the loopholes that were found over here. And you just keep going back and forth, which I think is how we ended up with this wildly complicated, kind of big, cumbersome boat of an industry that does not necessarily want to turn very quickly. Nothing seems to happen very fast in this industry. But I'm just curious. So you mentioned this earlier that we as a nation spend more per person than most other countries. I think any other country. And it's, if you compare us to most other like economic peers, it's close to double per person. With that much money, just in a vacuum, could you come up with a better system than what we have? Right? Not understand, like, is it possible from a political standpoint? Like, with the amount of money we throw at this, we should have better health, right?
Well, I love what you said, better health, not necessarily better health care. And I think it starts way upstream, starts early, in our childhood, of creating healthy behaviors. Yeah, my background is actually in public health, and I believe that if I didn't have to ever operate again on someone because they cared for themselves by eating right, moderating what they eat, avoiding harmful substances, getting enough sleep, good sleep, creating social connections, minimizing risky, uh, illicit behavior, I think that would be the ideal health industry.
Mm-hmm. Yeah, so that's actually how you and I first connected. I saw you speak at a conference in July of last year, and you were speaking largely on these lifestyle factors, right? It wasn't improving RAF scores. It wasn't, we're at a healthcare, it was, what is it, HMFA. It was like it was basically a bunch of people trying to figure out how to get reimbursed faster or more completely. And you were there talking about like lifestyle factors. I was like, okay, this is the most interesting talk I've seen at this conference. So speaking of like lifestyle factors, I'm not sure how to influence change in this space, right? Because like everything you just rattled off, none of it's going to be a surprise to people. Eating healthy, making sure you get enough sleep, managing your stress, have strong social connections and relationships, exercise, move your body, get sunlight. How do we start influencing this at scale? And I'm happy to start in a very theoretical way, and then we can kind of try to narrow down to how to actually implement that. But you have a background in public health. Like we've been trying to crack this for a while, right? A lot of people are trying to figure this out. It's hard. We have such a big country, 330 million people. It's hard to figure out solutions that work for everyone.
330 million people, 67% are overweight or obese. Significant amount of the population is also pre-diabetic or diabetic. Yeah, I wish I had the magic answer. I wish I had the Ozempic for behavior change. Uh, People want a quick fix, and unfortunately, it starts with really your mindset and the will, not just wanting to change, but the willingness and the understanding of how to change behavior. Um, I loved operating on people because it was a quick fix, but I also recognized that a lot of what I was operating for, whether it was injury or illness, could have been totally preventable or avoided by um, early recognition of disease and behavioral change. You know, maybe it's through gamification and incentivizing people in a way that will create some sort of external motivation for them to change their behavior. Maybe we can get to people through their own intrinsic motivators. Maybe it's creating more empathy and compassion. Or maybe we just are terrible at providing access to the right healthy choices, and people need support navigating a complex system.
I'm sure it's some of all of that. The point you mentioned earlier, which was psychological safety within a medical setting, that's something I want to kind of circle back to. I'm 35. Even just in my lifetime, I've seen the sense of community and the strength of relationships sort of diminish. I don't know if it's with the ability to travel and move is just a lot easier, or it's technology, or it's a combination of all these things where you can stay connected. For anyone listening, I'm air quoting connected through technology, and you can sort of outsource many parts of connection where you'd have to normally spend time with somebody, have a real conversation with somebody, go over to their house. Now you can post something on Instagram and get a few comments and likes, and that will get a similar feeling of connection, but it's very short. It's not long lasting, and it doesn't necessarily contribute to something positive, I don't think, in the long run. But I'm curious if you think, like, do you think the sense of community is also diminished? And I don't know. I feel like life is sort of cyclical, right? So I'm hoping that we're going to get to a shift back. I feel like we shifted away from community. And I'm curious if you think we're going to shift back towards more community almost out of necessity. Like, I don't know if we can get any more isolated from each other. At least I hope not.
Yeah, it's a bit of an oxymoron, right? Or a paradox. We can be global. We can have colleagues who are global that we communicate with every day. But are we really connected? Are we really creating those deep connections that impact how we feel toward one another? In fact, I think there's been so much that's come out of social media that's been great to allow us to do things like what we're doing today with podcasting. But then there's also the misinformation and the cyberbullying and the need for people to search for likes to feel good about themselves, where feeling good about yourself comes from within. It doesn't come from clicking on a thumbs up. You know, I've talked a lot about this, what you're bringing up, this safety and feeling uh, appreciated, wanted. I think we need to spend more time showing gratitude, um, recognizing people for what they do, and being open to diversity of thought, diversity of purpose. Things are very polarizing today. Um, and I think that's what you're alluding to is it's creating these dynamics where there's a loss of civility. And I mean, I don't want to bring the politics into it, but we saw this in healthcare where the violence against healthcare workers was staggering. And there was a loss of trust toward physicians, particularly, and even today, I think it still continues. Just you know, and I think physicians also we have a part in this because we have to remember that the way we were trained was a paternalistic approach. I say what you need. I say what you should do. So why aren't you doing it? Why aren't you adhering to the regimen? And maybe there's a different approach on how we get people to buy into healthy behavior.
Yeah. Yeah, it seems like the younger and younger generations, I don't even want to say want, but need things to be more collaborative. The paternal approach, as you described it, is I think being readily rejected by sort of the generation behind me, and they're much more in the collaborative camp. I also want to circle back to the point you made about access. I always go back and forth to this, right? Because I've spent a fair amount of time on social media, and especially in the health space, I kind of go back and forth. I'm like, is it worth putting a video up just informing people that eating lots of fruits and vegetables is important, and like that's important part of your diet? And I'm like, it's so simple. And then I end up I post something about that, and a lot of the comments are going like, oh, why do we even need to say this? Doesn't everyone know it? But I think there is still that piece of education. There's a study that came out looking at the SNAP program, where they looked at just the SNAP program, which is like food stamps or SNAP plus education. So people are on food stamps, but also some very basic nutrition education. And the result on the SNAP plus education was like 66% better outcomes. So it's like clearly this basic education is still a requirement. So it's hard to know where to even begin.
I love that you brought this up because I'm guilty of being one of those people. So I'm 54 years old. I grew up surfing. I was really mobile. I could surf big waves. And then a couple of years ago, probably right around when I turned 50, I was in Hawaii teaching my 10-year-old daughter how to surf. And I couldn't jump up on the board like I used to. I'm like, wait a minute, what happened? My mobility completely changed. My flexibility, my hips felt like they were stuck in the mud. Over the last couple of years, I look at YouTube shorts, and there are some incredible YouTube shorts that demonstrate hip mobility exercises that I just picked up from some random woman who is knowledgeable in physical therapy or in training athletes, and I do it. So, a guy like me who's a Gen Xer, I actually, it appeals to me to watch something for about 10 seconds and then learn how to do a new hip mobility exercise. And by the way, yeah, I can get back on my board and surf again because of these YouTube shorts.
So I've categorized things into access, education, and then action, where some people don't have access to, like, they know what they need to do, and they might even have the financial resources to do it, but they don't have, like, there's lots of ways you can parse out access. Some people have access and the willingness, but they just don't know what they should be doing. And then some people know what they should be doing. They have access, but they don't have the drive, the intrinsic or external motivation to take the action they want to do. So I guess from like a social determinants of health standpoint, there's no shortage of work that needs to be done in this space. Anytime somebody's knowledgeable in the space, I'm always curious to ask about social determinants of health. And you've also operated in healthcare much longer than I have. Have you seen progress in social determinant, I guess, like programs or initiatives? And where do you see our big opportunities that we still need to kind of make strides towards for make more progress there?
First time I heard social actually social and behavioral determinants of disease was in 2013. I was getting my master's at the Harvard School of Public Health, and it was incredibly interesting. We had a class just talking about social activities that would help promote health and prevent disease, like housing and food deserts. So that was about 10 years ago, the first time I heard it. And I've seen progress. I think there's legislation that's been passed requiring the insurers to incorporate health inequity uh, metrics to ensure that people of underserved communities are getting access to care. But I still think there's a long way to go. There's a tremendously, and I'll tell you where we're going to face the largest challenge right now is with generative AI and the algorithmic bias in machine learning not picking up the disparities in different racial, ethnic, religious, and other sexual orientation and gender identity. That's going to be a problem, which has to be addressed. So I guess a long-winded answer to address your question is we made some progress. I think there's attempts at being better, but again, it doesn't bring in the revenue into the healthcare industrial complex like a new drug does, or a procedure from a device.
Yeah, that's where it's hard, right? Like we all know we all know the answer, but is there enough money in place to get enough people on that side? And currently the answer is no.
I have a couple of colleagues that work for venture capital firms, and they don't want to hear it from me. If I'm talking about wellness or health, don't bother me with that. If you're talking about specialty care, well, listen.
Mm-hmm. Yeah, I was just out in Tampa, Florida for like a 1-day. It's like a 1-day conference. Not even a conference. There's like a private invite thing, but they just get together and it's like 50 of us just talking about one particular topic. And the topic this year was private equity in healthcare. And it was fun. In a group that small, you can have really animated conversation to say. And there were people there from the private equity side. There were people there from the healthcare side. And through 8-9 hours of conversation, you kind of get to the end of the day. And somebody asked the question, like, does any of this help patients? And everyone was like, oh, no, absolutely not. Just understanding the model of how physician practices get rolled up, how private equity is always going to need to make a return. They're not looking to hold on to those group of practices forever. They're looking to have an exit event, and then whoever they sell to, they need to make a return at some point. It's like somebody's going to be left holding the bag. But we as an industry just seem to be okay to continue down this route until, I don't know, it falls apart and we just have a bunch of independent physicians again.
78% of the physician workforce is employed by either a health system, or a hospital, by private equity, or a payer. In Oregon, actually, there is a legislation that is going through their, I think it's now in their Senate, to ban private equity from purchasing physician practices.
I did see that. Yep. I brought up that story because you'd mentioned how bringing up like wellness in those circles just is not well accepted. And it was funny because one guy there brought up kind of what we talked about earlier, like the younger generations. They're looking to homestead and they don't trust the medical system. And this guy got like 3 sentences into what he was saying before somebody cut him off. They're like, don't you bring your health and wellness stuff in here. But that's just how that side of the industry treats it. Cause it's just a commodity, right? Patients are their units to drive revenue. Unfortunately, but that's the reality of private equity. Um, do you have any? I don't want to end on such a morbid note. Do you have any encouragement towards like other models? Like I'm a big fan of direct primary care, because they are largely independent. There's some bigger groups like Marathon Health, and I think they're doing interesting stuff in the employer sponsored space. But if you have any thoughts on direct primary care or any other models that you see as encouraging, I'd love to hear that.
Yeah, I'd like to put a shout out to the American College of Lifestyle Medicine, because I think
Yep.
it's an important society that is now creating a certification and actually fellowship for physicians to encourage patients through lifestyle change or behavior change. And I believe that those models will be sustainable. I believe patients will appreciate those models much more. I believe the employers, so direct to employer, will appreciate those models because it'll lower their costs if they're self-funded with their insurance plans. I think they can work. An interesting model that I'm working on right now, and I won't get too deep in this because it's probably for another day, is I'm working with a company that's creating digital twins or of a physician and health coaches.
That's interesting.
Talk about access.
Yep.
So patients will have 24-hour access, daily access to the physician's digital twin for anything that relates to their personal or medical health history.
Hmm.
And it will occur through a virtual marketplace, through a portal that's HIPAA protected. So all the protected health information that you worry about will be protected. And to even take it one step further, there is a whole new digital currency that will come out of this.
That I'm sure of. So
those innovative approaches are coming.
So I think with generative AI and sort of these digital twins that you're describing, there's a lot of things through technology that are going to help augment the workforce. But are we going to be in a really bad place from a nurse, physician, basically just healthcare professional standpoint? Because like the problem with these jobs is like you can't spin them up really quick. Like it takes a lot of training and a lot of money to kind of get that training. Are we going to be okay from a workforce standpoint?
No,
No.
we're facing we're facing a major shortage of physicians and nurses. And I don't have the numbers offhand, but you can certainly look them up through the AAMC.
Mm-hmm.
Based on the number of exits and then the lack of interest to go through all that training and the cost of going to school, unless it's funded somehow. We're going to have to rely on other sources of delivering health.
I would like to see a future where it's all much more collaborative, because I think, to be fair to physicians especially, it's been a very unfair expectation of somebody to live their life usually until they're like 40, 45, and then they start getting things that happen with their health, and then they go, all right, fix me. Right? Like that's not a fair expectation. But there's lots of other like allied health professionals, right? I think there needs to be better coordination. What kind of dog do you have?
Oh, sorry. Yeah, I've got an Australian Shepherd who's...
That's fine. I've got two dogs here, so one of mine was barking earlier. It's no problem. I think in an ideal future, something that's like also realistic is go to a medical doctor, or maybe not even a medical doctor, but there needs to be someone quarterbacking care, whether it's a health coach or something like that. and then just much better coordination amongst other people, where you had a personal trainer, registered dietitian, nutritionists, health coaches, and then your nurses and then your sort of specialists as needed. I think a lot of it's been lumped into the medical world to this point inappropriately. And I think it needs to be more evenly distributed. But again, it's a money problem. So I don't know where the money and the resources come for all of that. And I think technology can help augment some of that, but usually not at a one-on-one level, usually at more a group level. I don't know. Those are just my thoughts on it, but that's just generally where I'm thinking. I was also trying to end up something more positive.
No, you're raising a really important point here about the direction we need to go for value-based care. And it's around creating a team. And as a physician, you can't possibly know all that needs to be done to care for someone, from their nutrition habits, their sleep habits, managing all the different chronic diseases. So if you have a team of health coaches, diabetes educators, personal trainers, that's the ideal situation. So the collaborative approach that you're talking about, and hopefully as the new generations of people are seeking out health, will appreciate that type of approach. That's the direction we need to go.
And I think starting people earlier, right? Because of all the different types of providers you and I just listed, there's many different tracks of education that can be fed to the patient, and a more educated person is going to be able to make better decisions on their own, which sort of transfers a lot of the agency and the autonomy back to the individual. Because I think within health, it seems like, just kind of as a personal trainer, then working in this industry, a lot of people don't feel like an active participant in their own health. It's sort of it happens to them and they're not really in control. So I think finding ways to shift that back to the individual will be very important, and also very empowering too.
Absolutely. Need to be you as a patient need to be your best advocate, and to learn as much as you can about your health.
Do you have any closing thoughts that you want to add, or that might be a nice place to wrap up right there?
Sure. Well, I'll just say that, for those who are interested in going into the healthcare profession, there's going to be tremendous opportunity. It's changing. It's going to be dynamic. And I'm excited about the future. For those who are navigating the healthcare system and maybe have felt frustrated or want more out of their experience, I do believe change is also on the horizon, and people are understanding that it's more than just that 5-minute interaction with your physician who's tapping on a keyboard. We're going to be moving away where there's going to be ambient technology where you can actually look at your patient in the eyes and have a meaningful conversation. That we need to get back to that type of patient care.
Yeah, I definitely think we can do it. It just takes, I think conversations like this are very important to inform people and also kind of give people hope, and also give them a direction to point their energy towards. I'm really thankful for you. You're definitely a leader in the industry. You're definitely shifting a lot of minds and perceptions in the right direction. So I just want to thank you again for coming on, being very generous with your time. And this conversation kind of went in a different direction than I expected, but I'm happy it did. We kind of ended up more on lifestyle than physician impairment, which is where we started, but it's the way these things go. But again, Dr. Scott Ellner, thanks so much for coming on.
Thanks for having me, Parker.
Hey everyone, that's all for today's show. I want to thank you so much for stopping by and watching, especially if you've made it all the way to this point. If you'd like to be notified when new episodes are going to be released, feel free to subscribe and make sure you hit the bell button as well. To learn more about today's guest, feel free to look in the description. You can also visit the podcast website, which is exploringhealthpodcast.com. That website will also be linked in the description. As always, likes, shares, comments are a huge help to me and to this channel and to the show. So any of that you can do, I would really appreciate. And again, thank you so much for watching, and I'll see you next time.